Hello, I'm Ed Birnbaum, a respiratory therapist with the Morlen Health home-based pulmonary rehabilitation program.
And I'm Saj Rambab, another one of the respiratory therapists at Morlen Health.
Thank you for being with us. Our topic today is the respiratory system.
Part of our pulmonary rehab educational series from Morlen Health. And please go to morlenhealth.com for more information, more videos, and other information about our program.
Our goals in this presentation are in turn here to provide an overview of how the respiratory system works normally when everything is normal, what goes wrong when you have chronic lung disease, and then ultimately the purpose of learning these things is to see how we can manage chronic lung disease, reduce symptoms, achieve our goals in life, and improve the overall quality of life when you or your loved one has a chronic lung disease.
So most of our topics and presentations are educational material, and it just gives you an overall better idea and a picture to take ownership of your healthcare.
Right. So why do we breathe? Why do we have respiration and breathing? Well, in life, we need energy to do the things we do, to do the work of living. Now, that energy comes for us, as it does for any internal combustion engine, that energy comes from burning fuel. In our case, the fuel is sugars that come from digestion of food, which is burned in order to create the energy to do that work. And when oxygen is necessary for that respiration to take place. And then there's a byproduct, carbon dioxide, that's the waste product that has to be gotten out. So we breathe to get fresh oxygen in and to get that carbon dioxide out. So that's respiration or cellular respiration, because each of those little cells, the millions of cells that make up our body, is a little internal combustion engine. And breathing is the mechanical work, getting the air in and out. Now we're going to talk about and show in detail the different components of the respiratory system that make all this possible and how they work.
And of note, the image that's here is, an aerial view of like a coral reef. And there's going to be a talk about a tree, an upside down tree later. And there's a lot of similarities between respiratory system and our bodies in nature. So it's interesting that this picture looks at like the cellular level of what lung tissue looks like. And we'll go next slides about how the lungs look like an upside down tree, and we get our oxygen from the air. So it's just interesting. Keep that in mind.
Right. So we're going to do a quick overview of the respiratory system, the parts of it as the air goes in and comes back out, and Saj is going to take you through it.
So real briefly, you can read all the parts here: the nose, the mouth, the larynx, trachea, also known as windpipe, bronchi or the bronchial tubes, or the airways and the alveoli. But for anatomically, we will breathe in here through the nose or through the mouth. And it's going to go, if you breathe in through the nose, it's going to go through those turbinates, pick up some moisture, get filtered out with the cilia, which is the hairs in the nose, and it's going to go down, and it's going to go through the epiglottis. Hopefully it's open. It's going to go into the trachea. Then you got the main stem bronchi here, and then here, and then you have it goes all the way to tertiary bronchia and to the alveoli on both sides.
Right. Now we're going to go into that in much more detail. And Saj will take us through the upper respiratory system. We divide the respiratory system into two major components: the upper respiratory system and the lower. And each of those plays a vital role. Let's talk more about the separate components that Saj was starting to talk about in much more detail and the important role that each one plays.
So the upper respiratory components, you have the nose, the nasal cavity, sinuses, and the pharynx. So the nose is here anteriorly, it's a lot more cartilaginous. So the cartilage is here, then you have the bone. And then here in the nasal cavity, you have the turbinates. So you have nasal hairs here, turbinates, so with mucus producing cells on it. So that helps trap more particles. Also helps moisten and heat the airway because you have more surface area because you're going through different levels. And then you have your sinuses here, which are to also for phonation, so for speaking. Also, it helps with pressure, and sometimes if you get a sinus infection, this can get filled with mucus as well. Um, and then you go down into the pharynx, and then you have your tonsils here, and then your oropharynx. And this goes into the trachea and the larynx and trachea, and that leads into more of where the demarcation is between the upper respiratory system and then the lower respiratory system.
Right now, a consistent theme as we go through all of the respiratory systems, starting with upper, going into lower, is that I explained that we need to get good stuff in, oxygen, and get the carbon dioxide out, but we want to keep bad stuff from getting in. We have to. We're talking about a system that keeps us going, keeps us alive, lets us do everything that we do in life. We don't want dirt in there. We don't want germs to get in. And our system, respiratory system, is set up very precisely to make that function happen. So the upper respiratory system is mainly keeping the bigger visible things that could cause damage, literally dirt and food from going down the wrong pipe so that it gets into the lungs instead of in the stomach and so on. So Saj already talked about nose hairs that kept out, did some filtering, the turbinates in the nose that have mucus that filters out some of the stuff that'll stay there instead of going farther down. And now we're going to go look at the larynx separately, and Saj will show how that keeps stuff from going down the wrong pipe, so to speak.
So the larynx has the larynx, vocal cords, and epiglottis. And here in this diagram, you can see that the larynx is the main area that contains these structures, or there's areas of the upper airway. So the real important thing here is the epiglottis and the vocal cords. Those keep particles from getting into your lungs, into the trachea. So when you swallow, it's going to come down here and close off the trachea. So the food, when you bite it and you chew it, it goes into the esophagus. So it's going to go into the feeding tube down to the stomach. Because if this epiglottis wasn't there, there's a likelihood that the food or other particles, saliva, can get into the trachea, and that's bad. And the other thing that also helps that is gravity, because the trachea is more anterior. So it's going this way, more anterior. So it's in the front part of the body, whereas the esophagus is on the back part of the body. So it just naturally, with gravity, it's just more prone to go right straight down back. It doesn't have to do this turn in. So it's a little bit easier with gravity because of the epiglottis. So you really want to make sure that, like Ed said, you don't want other particles to go into your trachea, into your lungs, because it can cause a lot of serious coughing and can cause damage down the road.
And a not uncommon problem. This is not rare. That Saj mentioned used the word aspiration once already, for especially liquids, more than big chunks of food. But it could be for that to get into the lungs, even in minute amounts, it can do some damage over time. Or stomach acid if you have regurgitation, okay, with even tiny amounts of acid, instead of staying down in your stomach, will work their way up, especially during the night if you're sleeping, into the pharynx and some of that might drip down into the lungs where it does damage cumulatively over time, or all at once, but especially over a period of time. So, this is an area where things can go wrong, but it's remarkable how well this system keeps our lungs pure and working well when everything is functioning properly. And now we're into the lower respiratory system, and we're going to go through this a little quickly and then again in more detail. So here you see the trachea uh, conducting air down to the bronchi, the bronchial tubes or airways. You can call them any of those things. And they branch smaller and smaller, 14 times before they get to the terminal uh, bronchioles and then into the air sacs where the oxygen actually goes into the bloodstream. Carbon dioxide comes out the other way. And Saj will talk about the bronchial tree. He mentioned it once, and then a little bit more about each of these things in some detail, and then in much more detail on the next slides.
So, yeah, the bronchial tree, as you mentioned, the tree, you talked about the ocean and the thing and the coral reef from the bird's eye view. If you were to turn this bronchial tree upside down, it does look like a tree. So, from the main part, the trunk of the tree, into the primary branches, and then just secondary branches into the leaves, which we can say are analogous to the alveoli, and that's where the good air comes in. It goes all the way down to the terminal airways into the alveoli. It pushes the oxygen over into the blood, and then at the same time, the carbon dioxide comes out. So the oxygen goes to the rest of the body, and the carbon dioxide comes through, comes back through the tubes, and comes out, and then you exhale it. So it's really important to know this, just a basic level, because at any level here, if you get an obstruction or you get an infection, it can change that. So it can change the level and the quality of the air that's getting into your body and the lungs. We're getting the oxygen, getting it all the way into your lungs, into your bloodstream.
Right. So now in the next slide, let's look at those alveoli, the air sacs, in still more detail. Oh, I'm sorry. Here's an overview of the lungs. So the just another way to take a look at them and mention a little bit about the anatomy, so that when your pulmonologist talks to you about your own situation or about your loved one, you'll have some idea to understand the vocabulary that they use when they say, where they're finding a problem possibly. So I'll just do that real quick here. We have the right and left lung. Okay. So the right lung, it's like they're two separate organs, but they are, of course, joined where they meet the windpipe, the trachea. Okay. And the right lung has 3 lobes, and we say that the left lung has 2 lobes, plus something called a lingula. And a physician might say, well, on the X-ray we saw X, Y, or Z in the right upper lobe. Sagittal flash on that just a little bit, or the left lower lobe. That's what we're talking about there. And take a look also at the diaphragm. It is 2 separate muscles that kind of function together as one. So we'll say the diaphragm, but they might also talk about the left hemidiaphragm or half diaphragm is in a way a separate muscle. Now that's right under your lungs, attached to the membrane that surrounds the lungs, and it's above your stomach. And if all of you that are looking at this video with us right now, put your hands over the abdominal area and pant a little bit like that, and you'll feel that diaphragm moving. And now you know where it is. It's a big, strong muscle, and it's your main, not the only, but the main muscle used for breathing. Okay. And then there are the bronchi, the bronchial tubes that go through those lungs to the right and branching smaller and smaller, and to the left. So now we'll get into the alveoli. And Saj, I'll let your voice replace mine for a little while here. Why don't you talk about the alveoli in a little bit of detail there?
So here is a really good diagram of the alveoli and how the oxygen goes in and the carbon dioxide comes out. So the air comes in, oxygen goes over into the red blood cells, and then also at the same time, the carbon dioxide is coming out into the alveoli as a gas form, and then it's being breathed out. So the gas exchange is happening down here at this level, right? So the blood's flowing through, oxygen is coming in, CO2 is going out all at the same time. So the air comes through these, terminal airways, and it goes into these alveoli, and they have the alveolar sacs. You have the alveolar ducts that bring it into here, and you have the whole thing is the alveoli in essence. And you could say it's like the the leaves, the terminal leaves on a tree, or a bunch of grapes. They're all combined, and this, because they're all these little circular areas, those little bunches, those little individual sacs, it increases the surface area. So the more surface area, the more likely and the greater chance of this gas exchange from happening. So the oxygen coming in and the CO2 going out.
Right. And that's and Saj gave a really good explanation of how that gas exchange takes place. The alveoli also play a very important role in the mechanics of getting the air in and out because they are also like balloons. Now, when you blow up a balloon and get some air into it, if you let go and don't keep the air in there, it just comes out on its own, doesn't it? Because the outer part of that balloon is elastic. So it will go back to its original size when everything is relaxed, and so do the membranes around those alveolar sacs. Okay, those airways. Remarkably, they can do that at the same time that they let oxygen and carbon dioxide pass through in opposite directions. But that elasticity is very, very, very important. Okay. So again, if you take a deep breath in, deep as you can, and then let go, the alveoli, when they're left alone, they go back to their original size. They don't empty all the way out like a balloon would. They empty to just the right amount of air being left in there. So the next breath is easy. You don't have to restart that balloon open, which takes so much more effort. When there's a little air in there, you can expand them the rest of the way that you need to without much work. Now, that's when everything is working properly. Okay. Now we'll go to the next slide. Now, so that helps explain how breathing takes place. Inspiration, inhaling air, you're stretching those alveoli open, and you're also moving your ribs outward as you make your chest bigger. Now they function like springs. The alveoli, like balloons, pull the air back out. Let as they shrink back. The springs, those springy ribs, come back to their original shape, and all of that without any effort uh, gets the air out. Now, the work of expanding the lungs is mostly done by the diaphragm. That's why we looked at it earlier and had you find out where yours is. Saj is showing how it's kind of bowed upward in its relaxed state and pulls downward to make the chest bigger. Okay. There are also muscles between the ribs, and in the diagram there, it mentions intercostal, which means between the ribs, intercostal muscles. Also, some muscles up in your shoulder and neck area also can pull up to make the lungs expand even further, and some other abdominal muscles, in addition to the diaphragm, can get involved to stretch the lungs open or make you breathe faster than would happen without using them. But for relaxed breathing, the diaphragm does at least most of the work. Now, exhalation is when those springy ribs come back and the balloony like alveoli go back to their normal size, and the air comes out. But you can get these other muscles between the ribs, around the neck and shoulders, the other abdominal muscles involved as well to one degree or another. But that's how breathing takes place normally. Again, all of this to show how things are working normally.
And one thing to note is that inspiration is more of an active process, and exhalation or breathing out is more of a passive one. So you let your chest muscles recoil and your diaphragm just go back, and that would cause you to exhale.
That's right. And it's important that you hear that, because one thing we do when people have lung disease, we're talking about normal breathing now, but when people have problems with breathing and are short of breath, they can learn how to manage their use of muscles and the speed at which they breathe so that they're less short of breath. That's one way we can manage problems from chronic lung disease. We can't go into much detail about that, but that's important to take home from this. Now, one more component of the normal respiratory system when it's not sick is the mucociliary system or subsystem. This is going on. We've talked about keeping bad things out of the lungs. We talked about nose hairs and the epiglottis and the vocal cords and so on going down until we got into the lungs. Now we're in the lungs, and hopefully none of those big pieces of bad stuff got through. Now there's other things in the air though that are, maybe even microscopic, like germs, bacteria, viruses, little tiny bits of dust. We don't want any of that to stay in the lungs either, do we? We don't want it in there, and we want to get it out when it gets that far. So that's the job of the mucociliary system. So looking at the diagrams here, healthy mucociliary escalator, okay? So you see a big green germ or something there. That's something bad that we want to keep out. Okay, that's going up the escalator. What is that escalator? Well, that escalator is composed of things that are so tiny, so microscopic that even any microscope that we're liable to have in a clinic or in a hospital isn't going to be able to show them. They're that tiny. But there are cilia, which simply means hairs, lining lining the membrane that surrounds each of those bronchial tubes. And on top of those cilia is a layer of mucus that's just the right consistency, not too thick, thin enough that it can move, but thick enough that it's a little bit sticky, and all that junk, germs, dust, stick to it. And the cilia keep that escalator moving by beating in an upward direction out of the lungs, up toward your windpipe, and it keeps going until it dissolves in the saliva that we all naturally have in our mouths and throats, right? In that pharynx and that upper respiratory system. And when it dissolves there and you swallow that mucus, tiny amounts of it, not enough that you're even aware of it unless you're sick, then it goes where? To the stomach. And the stomach has acid in there that digests all of our food. It digests all that junk too, kills the germs before they can grow. So you don't get infected. You don't get infected in your stomach, and it never gets down low enough, long enough in the lungs, in those tiny bronchioles and air sacs, so that it's not there long enough to infect you or do any damage, and you don't get plugged up. Now, when it's unhealthy, because if you have been smoking, many people who smoke, not all, but many, get inflammation in the lining of those bronchial tubes. They get damage done to that mucociliary system. The mucus gets too thick. The cilia are damaged and not moving or not even there. Some of them are ripped out, and now you get plugged up. Okay. But when things are working well, it's a really wonderful system. And we can't go into any detail, but when you stop smoking, it can regenerate at least to a major degree and things get better again.
Yeah, it's very important to get that mucus out of your lungs, whether you spit it out into the trash or to a napkin or you swallow it. I know it sounds gross, but it's better to have all that mucus, that sputum, out of your lungs and somewhere else, as opposed to letting it stay in there and fester and get into a pneumonia.
So now what goes wrong when you have chronic lung disease? Now, of course, we can't go into any detail about the different kinds of chronic lung diseases, but they basically break down into a relatively knowable amount to learn. Okay, and we can talk in general about two basic types: obstructive versus restrictive. Okay, obstructive in general means the air is harder to get out. So stale air builds up in your lungs, which actually get bigger. And you can see on the obstructive side there, that lung is much, much, much bigger, over inflated. Okay, so that it doesn't function as well as it should. Versus on the other side, restrictive, the lungs are smaller could be for a variety of reasons, and they don't get inflated well, and it's more work to breathe to get the air in. Both of these cause more work of breathing, and it's harder to breathe. And in the next slide, we'll go into a little bit more about each one. So obstructive lung diseases, the ones overwhelmingly, the great majority of them are either asthma or COPD or some combination of the two. So what's making the air get obstructed? Well, with almost all asthma and with a lot of COPD, the great majority of people with COPD have some amount of bronchospasm. So the airways are spasming, literally tightening up. And the inner lining of the airways, when they're inflamed, which they either always or some of the time inflamed, get thicker. So for both of those reasons, either the muscle tissue that's built into all of our airways, normal airways, is spasming and constricting those bronchial tubes, making them smaller. Okay, inhalers can help relax them, but that's what's happening. Or they're thicker and the air has a harder time getting through. Now, I'm saying that the air is having a harder time getting out. You think it's having a harder time getting in. Well, when you inhale, you're making those bronchial tubes actually open up just by inhaling. It's when you're exhaling that they normally get smaller. And if they're smaller than they should be, that's when the air kind of gets pinched and trapped inside. Now, let's look at the alveoli. This happens mainly with COPD, or as we might say, emphysema is a component of most COPD, or at least a lot of it. Then the alveoli are also affected. In addition to those bronchial tubes, they are damaged, can be by smoke or pollution. Okay, a cigarette smoke or other smoke or pollution, can be from some other diseases can make this happen, even in non-smokers. But those alveoli are damaged, and they get torn. Okay, they get bigger, floppier. And remember, we talked about how the alveoli should be elastic, like a balloon. You inhale, and then they empty on their own. Well, that doesn't stop altogether with emphysema or COPD, but to some extent, maybe some of the alveoli more than others. So some parts of the lung more than others, but you lose some of that elasticity. And instead of being like a balloon, the alveoli or the lungs as a whole become more like paper bags. You blow up a paper bag and you can walk away from it, and 10 years later, it's still full of air, isn't it? The air didn't come out on its own. You have to push it out. So that takes extra work. So that in both of these ways, the tightening of those tubes and possibly damage to those alveolar air sacs, you're doing more work to empty their lungs, and they actually get overinflated, and too much stale air stays in there more than it should. That's obstructive lung disease.
That's right.
Now, with restrictive air lung disease, instead of an obstruction on the way out, the air can't get in as it should normally do. And that can be for a variety of reasons. Now, over on the left, we're talking the slide on the left, you see where the alveoli are smaller, the membranes around them are thicker, That comes from a big variety of a large number of different diseases. But in general, you'll hear something like interstitial lung disease in describing these, and or fibrosis or fibrotic lung disease. Fibrosis meaning that that tissue is actually changed. It's become fibrotic. It's not as elastic as it's supposed to be. It's thicker, harder to get air in. They just don't want to open up so well. Um, there can be other features, but those are the major features. Now, over in the right, we're looking at two different graphics. This person here that's being pointed to has some kind of curvature of the spine. That makes the chest smaller. And no matter what you do, you just can't get as much air in there. There just isn't room. So that's a restriction of the breathing. Scoliosis and kyphosis are two types of curvature of the spine that affects quite a few people, and it can affect their respiratory status. Okay. And then up above, where we're looking at the diaphragm, and in one of those, remember the diaphragm is made of two halves, and one of them, the stomach is taking up space because of a hernia. Okay, that can be one thing that's going on. That's actually letting the stomach take up room uh, that should go to the chest, right? Should go to the lungs, and that's another reason why the lungs can't be inflated all the way, so the air is restricted. Some people have some paralysis as well. It can be just partial or complete paralysis of the diaphragm, so it isn't working, or other muscular paralysis or nerve disease that the lungs don't function normally. That's another kind of restrictive lung disease. We're not going to go into much detail about those, but that does happen. Okay.
Yes.
So is it, chronic lung disease cannot be cured. That's what chronic means. Any chronic disease can be managed. We can do things that make it reduce symptoms, make us do better, but it's not curable. But it can be managed to the degree that, to a point where actually you can achieve some of the goals you have in life. And so, what are some ways to manage it? Well, medications, we can't go into any detail, but sometimes including oxygen, can relax constricted bronchial tubes, can slow down the advance of fibrotic lung disease, and so on. They help. But education helps a lot. There are a lot of non medical things. One thing is learning what those medications do for you. Sometimes your providers give you the best medicines, but may not have time or skill to help you use them effectively. There can be things to learn that make them work better. Education can do other things for us too. Just knowing things can help you do better. Managing shortness of breath. I mentioned a little bit about learning how to breathe more efficiently, and other ways too that we can do better and have less shortness of breath, be bothered less by it. Other consequences of chronic lung disease. It affects people in terms of how well they can eat, but learning how to eat better, improving your nutrition can make you breathe better. Uh, these diseases affect your mental health, and mental health problems in turn affect your breathing, make it harder to breathe. Mobility, social isolation. These things can be managed better, and you can live much better. Learning how to exercise and getting going in exercise always helps you uh, do better with a chronic lung disease. And all of these are components of pulmonary rehabilitation. Morlen Health home-based pulmonary rehabilitation uh, lets you get that going without leaving home. You get hooked up through your computer or your digital devices, and there are a number of good programs out there. And this might be the best thing for you or your loved one.
And pulmonary rehab, like Ed said, combines all of the above. And really, like I said before, it's going to empower you to take ownership of your healthcare and to learn about it, your disease process, and be as informed as possible so you can ask your providers questions and concerns that you have during your appointments.
So thank you for joining us for this presentation. I hope it's been helpful to you.
Thanks again for taking the time to listen to our presentation and watch our presentation from Morlen Health. Please go to morlenhealth.com for more information about our program. And we have other video links and other information about other topics that we do cover and what our program is about, and links to other more detailed information as well. Thank you so much.
Bye-bye.